A very good evening, everyone. It gives me great pleasure to introduce everyone over here and welcome everyone. And today, we all know is World Preeclampsia Day. And on this day, we have gathered here to talk about this very dreadful condition which we all are very scared of. And at one time, I remember when I was doing my post-graduation, we had a separate eclampsia room in our hospital, and it used to be always flooded with patients, and it was the dark room of the hospital where no noise, and it was such a condition. So from that day to this day, when now the incidence has dropped dramatically, so that speaks volumes for the humongous work that obstetricians and gynecologists have been doing over the decades. So today at the outset, before we start any program of ours, we go with the Shiv Vandana. So Mahamrityunjay Mantra, please. Yeah, at the outset, good evening, everyone. I would like to invite the chief guest of the program, Dr. Shyam Desai. And whenever he's at the dais, I'm always spellbound by his lectures. So he is an obstetrician, gynecologist, endoscopic surgeon. He's been past president of FOGSI. And I believe, sir, you are now the president of CHAIRPERSON. Past president FOGSI, past president Mumbai OBGYN Society, past president IAGE 2003 to 2005, vice chairman ICOG in 2006, president CFOG currently, chairman maternal and perinatal health committee AOFOG to 2009 to 2013, chairman board of trustees Mumbai OBGYN Society for 7 years, teacher at the Mumbai University for 30 years, honorary professor Wadia Hospital 25 years, and consultant Port Trust Hospital. So welcome, Dr. Shyam Desai. It's always a pleasure to hear you. Please give us your words of blessings.
Yeah, thank you. And thank you for inviting me to be a chief guest in this webinar. Now on the hypertensive day. So it's very appropriate that we have this webinar on this day that has been designated as the hypertension day. In fact, as Dr. Ranjana Khanna was saying, when we were residents, they used to have a special eclampsia room. But now that eclampsia room is no longer there, we shift the patient straight to the ICU. And the entire prognosis of a patient is altered when the patient has blood pressure problems. Now, it could be in the first trimester, it could be late in the third trimester and during delivery, that these hypertensive problems manifest themselves. Where we could have severe preeclampsia, it could even go to the extent of the HELP syndrome, or you could even have the patient having postpartum eclampsia. And therefore, it is something which all the obstetricians should know how to manage right from the beginning till the entire delivery and postpartum period are over. I congratulate you, and you have an extremely good program. You have Dr. Ranjana Khanna herself speaking, giving an overall overview. And you have the severe preeclampsia being discussed, the HELP syndrome, and I congratulate all of you for having organized this webinar and wish you all the very best.
Thank you so much, sir. Thanks a lot, sir, for these pearls of wisdom. And it's always a pleasure, sir, to hear you. I wish you could speak more and more, because I always find it very fascinating hearing your talks.
Thank you. Thank you.
Thank you so much, sir.
Okay.
And now I would like to call upon the guest of honor, our very dear ma'am. Please unmute yourself, Dr. Sonia. Please unmute yourself. You're muted.
I will muted myself. Thank you, Dr.
Anji. A very, very warm welcome to Dr. Sonia Malik, ma'am, one of the most respected gynecologists we have in our country. And she's been the past Indian Fertility Society 2014 to 16, chair in Fertility Committee of FOGSI 2014 to 16, past president Indian Menopause Society 2007 to 8, associate editor,
I think we
Southeast.
can leave it, Dr. Khanna. Let's just skip it. We won't have time for the.
And lots of awards, and lots of awards. And she's director and HOD
Thank you.
South End
Thank
Fertility
you.
and IVF Center.
Thank
So
you.
welcome, Dr. Sonia Malik.
Thank
And
you.
I would like to give you to hear your views about this World Preeclampsia Day, which we so much dreaded by the obstetricians, and even the IVF specialists dread this condition because it is since more and more girls are conceiving at an increasing age. So this incidence is also increasing of gestational hypertension and PET. So ma'am, your views and your blessings, please.
Thank you so much, Dr. Khanna. First of all, congratulations. And thank you for this very thoughtful webinar on this day. It is very well chosen, and I think all of us should be really, really aware of this. And I also belong to the same era as Dr. Shyam Desai and yourself, when eclampsia was at its peak, and we were also scared of it, you know. But of course, now we have come down to a state where we are able to diagnose this condition or preempt this condition, I would say, that by various tests that we do during our antenatal period, where we can actually prophesy that this patient is going to have hypertension or she is going to have preeclampsia, I would say. So we have moved on a lot. And I would just like to mention a couple of things that we have been doing in IVF, which would prophesy and which could help you also to know, you know, whether it is going to be a hypertensive disorder or not. One, of course, we all must understand that there is something called the HLA typing of the man and the woman. So there is an HLA typing of C30. If that is present, then this embryo is going to cause preeclampsia to the baby, to the mother. So that is also now known. Then, of course, we also have this thing about AMH. We all talk about AMH, but AMH, if it is high, as we have in a PCO or in others, is anyway, if the AMH is towards the higher side, and if the AMH does not drop in the first trimester of pregnancy, then this patient is going to develop preeclampsia in the second trimester. So that is something very important and very interesting that you all should now be careful about and watchful of. That if there is no drop in the AMH, then you should be wary that this patient is going to have a preterm birth and having some kind of hypertensive disorder. And the third thing is this FET. When we are doing frozen embryo transfer and we are using the HRT protocol where we are using the hormones, there also the babies are big and the mothers are prone to hypertensive disorders and diabetes during their pregnancy. So these are some conditions which are iatrogenic and which probably we can also prevent. So we all must be aware of all these new things that are coming up. And of course, you all are, as it is, we all are diagnosing this in our first trimester scans as well, where we are trying to see whether there is a preeclampsia score, I believe, which is now being used, and that is the ultrasound people have been a great help with that. And with that, we can really diagnose whether this patient is really going to have this kind of a problem or not. So I think we've moved a lot. We've really moved a long way. And from what we were, like we were having this dreaded eclampsia, we have moved on to preventing everything now. So kudos to the community and kudos to all the gynecologists and obstetricians. Thank you very much once again for having me here. Thank you. Thank you.
Thank you so much, Dr. Sonia ji. You have given us a wonderful food for thought, and that certainly makes you one of the best IVF persona in the country. So nice of you to tell us these little tidbits of which most of us were not aware of. So thank you once again, and it was really, really kind of you to join and a pleasure hearing you.
Thank you, Dr. Khanna, for having me. Thank you so much.
Thank you so much, ma'am. And now I would request our second guest of honor, Dr. Anita Sabharwal, a very good friend of mine. And she is a FOGSI champion, Wonder Foxians, FOGSI superstar, recipient of FOGSI Dhira Award, International FOGSI Achiever Award. Name it and she has it. And she is full of life. She gives us all the energies. I feel, Anita, it's because of you, seeing you, that we get more and more energized to do our work. And you surely bring a spark to everyone's life, to the life of all the Foxians. And you've been past chairperson, Adolescent Health Committee, AOGD, executive member of AOGD, and certified UNICEF GBV trainer, national faculty with IMA and GOI 2006, and joint secretary, public awareness, NARCHI, and so much more. And she is president, Forum of Obstetricians and Gynecologists of South Delhi. So over to you, Dr. Anita. Please give us some insight into this topic on this auspicious day.
Thank you so much, Dr. Ranjana Khanna, ma'am. I'm really touched by such kind words and love from you. Truly, and I think it's all because of great friends like you. Truly, friends add so much humor, fascination, and beauty into life. And as Dr. Sonia Malik ji just said, like she's such a big person, and you have given me the opportunity to share the same platform as Dr. Sonia Malik ma'am is. So I am already feeling on top of the world. And because she used the word prevention, and I am very much into that level, I'm always talking, working at the prevention level, awareness. As you know, I'm also the North Zone coordinator of public awareness. So as we all know this again, today you are speaking about such a big subject, hypertensive disorders in pregnancy. And we can really save so many mothers just by creating awareness about prevention. Because it can be prevented, it can be treated also if patients come well in time. Because I've also seen in my 40 years practice in a very slow socio-economical areas, because people don't know about it. And they reach the places when everything is almost gone. So they come at level. So we can really prevent it by taking care of our diets, by taking care of our weights, because if weights are within limits and we are following all our natural 6 doctors, as you said, I am always on the Facebook telling Amesha about these 6 natural doctors: fresh water, air, sun, light, and then good diet, and a proper sleep, good sleep for 8 hours, and good exercise. We all, as they say, early to rise makes the man healthy, wealthy, and wise. So these things are really true. But then still, if people have problems, then people like you are there. If they come to you well in time, you can again save them. And that's why, as you said, now we've really, in our days, we used to have those rooms and we used to be so scared that now this patient has gone into this eclampsia room, she may not come back. But now it's not happening like this. This is all because people come to us well in time and we save their lives. So again, if more people are getting awareness and they do all these steps, definitely we will be able to even eradicate from country. So thank you so much for giving me the opportunity, and wishing you all the best for your this webinar and many more, and for your all future events. I still can't forget your Prayagraj conference. It was so wonderful. It's still in my heart. Thank you so much. I hope to come to your conferences again and again.
Thank you so much. Thank you so much, Anita. And Sonia ji, आपका अभी pending है प्रयागराज. So now I will like
to for your
conference.
I came for the conference. I
was there, ma'am.
I was there.
Acha, you were there. Oh yes.
She was very much there. We were together.
Sonia ji was very much here this time.
Yes, yes.
Dr. Alka Kriplani is still on the that list.
Under your target. She's on the target. Huh? She's on the hit list. She's on the hit list.
Sonia dear, come.
Thank you. Yeah.
Thank you all so much. And now I would like to hand over the proceedings of the webinar to Dr. Amita Tripathi, who is the Honorary Secretary of ISOPARB Prayagraj. And she has been the chairperson of the Women's Wing of AMA Prayagraj. And she is a very, very dynamic person and always willing to help people in trouble. So, Amita, you please take over now.
Thank you, Ranjana ma'am. And Good evening and a very warm welcome from my side to all the Christian delegates. A very warm welcome to Udaipur, Bikaner and Allahabad Society for joining and holding our hand in this webinar.
Good evening, everyone, and we thank the esteemed faculty and the attendees. We take this opportunity and are pleased to announce our recently launched women's health website, that is mysakhi.in. It's a CSR initiative of Jagsonpal Pharma Ltd. As you are aware, Jagsonpal Pharma Ltd is one of the leading pharmaceutical companies in women health, and we have taken up this initiative as a part of our commitment to improving women's health across all life stages, from adolescence to menopause. This is the homepage of our website, mysakhi.in, recently launched last week. We'll be starting with this, the menopause initiative in this website, and we will be covering all aspects of menopause. The website is an extension of our ongoing CSR initiative of Jagsonpal, which is promoting women's health and hygiene. The company has already made this positive impact by building sanitation facilities at girls' schools in Punjab, Haryana, and Uttarakhand, as well as raising awareness about menstrual hygiene. With this website, mysakhi.in, we shall be focusing on providing educational content, initially focusing on menopause, where we have started with the public awareness programs. 2 programs are already held, and the third one is now this Friday. These sessions are being held every Friday, and these sessions will feature live interactive virtual discussions, and the recordings will be available on the website mysakhi.in for wider access. And we look forward to having many more active experts in the field of menopause through, join us in our quest to spread awareness and promote better management of women's health. So as a part of this initiative, we shall be having webinars every Friday, which will be focused on public awareness and menopause and the related concerns. Other than this, the website shall also be providing content which will be scientifically vetted for the lay public to be accessible in languages which will be more than just English. We will have 9 other languages apart from Hindi and English. So this website will be accessible to all, so that without their language preferences, also they can access the website according to their language preferences. So we thank you all very much, and this initiative, the CSR initiative Jagsonpal Pharma, is what I wanted to highlight today. mysakhi.in is the name of our website. Do log in and be a part in spreading awareness for the betterment of women health. Thank you so very much. And now we proceed with the webinar. Dr. Amita Tripathi, ma'am, please take over.
So congratulations, Jagsonpal, for this wonderful initiative. So starting without wasting any time, starting with the first session, the overview of hypertensive disorders in pregnancy would be taken by our founder president, Dr. Ranjana Khanna, ma'am. And to chair the session, we have with us our friends from Udaipur Society. Please, Dr. Rajshree Bissa. She is presently working as consultant gynecologist, obstetrician, and sonologist as Astha Hospital and Sonography Center, Pratap. There is one Pratapgarh at Rajasthan also. She has a special interest in infertility, sutureless NDVH, and Garbhasanskar, that is holistic approach and lifestyle therapy from pre-conception to antenatal period for the better pregnancy outcome and overall development of child. Welcome, Dr. Rajshree. And our next chairperson is Secretary of Udaipur Obs and Gynae Society, and he is Director and Consultant Narayani Women Hospital and Fertility Center. And we are so very thankful to Dr. Pradeep for coordinating with everyone and giving us so lovely speakers and chairpersons. And with this, I would request Dr. Rajshree to kindly introduce the speaker for this session, Dr. Ranjana Khanna, ma'am.
Okay. Good afternoon, dear colleagues. Our topic for today's webinar is hypertensive disorders in pregnancy. It is my privilege to introduce you our eminent speaker, Dr. Ranjana Khanna ma'am. She is Senior Consultant and Director, Ranjana Hospital, Prayagraj. She had been National Vice President, FOGSI 2017, President, AOGS, Allahabad 2013-17, Organizing Secretary, National FOGSI Conference, Varma 2016. She was Organizing Chairperson, National FOGSI Conference, Scientific Sangam Prayagraj 2023, Obstetrics Dilemma Prayagraj 2022, BOS The Trilogy Delhi 2017. She is founder president of ISOPARB Prayagraj 2021-25, ICOG Government Governing Council member 2021-25, executive member National ISOPARB 2023-25. She has received many prestigious national awards: FOGSI Achievers Awards 2022, FOGSI Dhira Awards 2022, FOGSI Dr. D.K. Dark Reproductive Health Care Promotion Trophy AICOG 2015, FOGSI Smriti Milans Award Save the Girl Child 2013. She is faculty at national and international conferences, IMA, Excel Refresher Course 2022-23, and webinars. She delivers the prestigious Dr. Prabha Malhotra Oration 2023, UPCOG Lucknow. She is author of many articles and chapters in various books and journals. She is convener of FOGSI GCPR on epilepsy in pregnancy. Presenting to you, Dr. Ranjana Khanna ma'am.
Thank you so much, Dr. Rajshree, for this lovely introduction. Yeah, so today I'm going to speak on overview of managing hypertensive disorders in pregnancy. This will give us all a very, in a nutshell, the whole scenario. So next. ACOG has classified hypertension in pregnancy as gestational, preeclampsia, eclampsia, superimposed preeclampsia, and chronic hypertension. So next, we'll talk about gestational hypertension. That is when the BP is more than 140/90 on two separate occasions at least 4 hours apart, occurring after 20 weeks of gestation. This is a transient diagnosis with normalization of BP by 12 weeks postpartum. Chronic hypertension is when the BP is more than 140/90 predating conception. That is, before she had conceived, also she was hypertensive. Identified prior to 20 weeks of gestations and persists even after 12 weeks of gestation, 12 weeks postpartum. Use of antihypertensive medications before pregnancy is the past history of the patient. Yeah. Preeclampsia occurs after 20 weeks of pregnancy. Blood pressure is more than 140/90 or even higher. Proteinuria 0.3 grams protein or higher in a 24-hour urine specimen, or more than +1 per dipstick, or PC ratio more than 0.3 milligram per deciliter. Or in the absence of proteinuria, new onset hypertension with the new onset of any of the following, like thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. Eclampsia, the much dreaded disease, presence of new onset grand mal seizures in a pregnant woman with preeclampsia, but we have to rule out idiopathic seizure disorder or other central nervous system pathology such as intracranial hemorrhage, bleeding, arteriovenous malformations, or ruptured aneurysm. Superimposed preeclampsia, that is new onset in a woman with hypertension prior to 20 weeks of gestation, sudden increase in proteinuria if already present in early gestation, sudden increase in BP, development of HELP syndrome, development of headaches, scotomata, or epigastric pain. What are the incidents? Hypertension are common and complicate obstetrical practice in India. Incidence of preeclampsia in hospital practice in India varies from 5 to 15%, and the incidence of eclampsia is now about 1.5%. Next. Etiopathogenesis we won't be discussing in detail. But yes, placenta has a lot to do with this, and there could be immunological factors, genetic factors, environmental factors, and ultimately it leads to FGR, HELP syndrome, eclampsia. Then there could be proteinuria, hypertension, so whole gamut of problems associated with uh, this hypertension and this placental dysfunction. Now, how do we manage gestational hypertension? Next. Initial evaluation, the mother has to be initially evaluated. CBC is done with the platelet count, serum creatinine, liver function tests, urine protein, and symptoms of severe preeclampsia are looked into. Fetal evaluation, ultrasound for fetal weight and amniotic fluid index, non-stress test, and biophysical profile if the NST is non-reactive. Further, we will continue to evaluate, and fetal evaluation kick count is seen daily, ultrasound every 3 weeks, amniotic fluid volume once a week, NST weekly in gestational hypertension, twice a week for preeclampsia, maternal evaluation, blood pressure at every visit, and evaluate proteinuria also at the same time. Laboratory tests, CBC, liver enzyme, serum creatinine once a week. Now, what is the advice that we give to patients antenatally? Women are instructed to report symptoms of severe preeclampsia. That is, suddenly if she has headache or visual changes, epigastric pain, shortness of breath, and immediately if there's any obstetrical complication like uterine contractions, pains, leaking, then vaginal spotting and decreased fetal movements, then also she has to report to the consulting physician. I have obstetrician. Yeah, next. Now, how do we manage? Pure gestational hypertension is only there in 6% of pregnant females. 1/3 may develop preeclampsia. In the absence of preeclampsia, maternal and fetal outcomes are usually normal. Initial treatment is lifestyle and diet modifications. A diet low in fat and salt and rich in calcium is recommended. Relative bed rest, that is, you don't advise absolutely bed rest, but yes, she can move around a bit, and light exercises are advised. BP is monitored once or twice weekly. Frequent ANC visits are advised every 15 days till 34 weeks, once a week. After that, proteinuria is checked at each visit. If BP is not controlled, start antihypertensives. Labetalol, nifedipine, hydrolazine are the usual drugs. Fetal monitoring by ultrasound, growth assessment, LycoRed volume, Doppler studies are done to see for FGR. Induction of labor is done after 37 weeks to terminate the pregnancy. How do we manage preeclampsia? What is the goal of treatment? To maintain a safe blood pressure, to monitor the mother for deteriorating condition, to monitor the fetus for signs of placental dysfunction and growth restriction. Clinical risk factors for preeclampsia: primiparity, previous preeclamptic pregnancy, chronic hypertension or renal disease, history of thrombophilia, multifetal pregnancy, IVF pregnancies, family history of preeclampsia, diabetes mellitus, obesity, SLE, and advanced age more than 40 years. So prevention, what is very, very important nowadays in the preventive aspect is where the dietary calcium intake is low. 1.5 to 2 grams of elemental calcium is given daily. WHO recommends calcium intake as early as the first trimester of pregnancy. So what is very important now is that calcium intake should go very heavy, 1.5 to 2 grams daily. And 150 milligrams of aspirin is started from 14 weeks of gestation. Next. Preeclampsia screening is very important so that we are forewarned and so we'll be forearmed. So screening, Doppler studies, uterine artery pulsatility index, diastolic notch, which give us a warning that yes, this patient could become preeclamptic. Biochemical markers, soluble FMS like tyrosine kinase, placental growth factors, and soluble endoglin. Maternal characteristics like increased age and past history of preeclampsia. Next. Now, preeclampsia with the absence of severe manifestations has often been characterized as mild, but it should be noted that this characterization can be misleading. Even in the absence of severe disease, morbidity and mortality are significantly increased in a case of preeclampsia. Therefore, we use the term preeclampsia without severe features instead of mild preeclampsia. So, when the severe features of preeclampsia could be any of these findings, when the blood pressure becomes more than 160 by 110 on 2 occasions, 4 hours apart while the patient is on rest, and thrombocytopenia platelet count going less than 1 lakh, impaired liver function, progressive renal insufficiency, serum creatinine concentration more than 1.1 milligram per deciliter, or doubling of the serum creatinine concentration in the absence of other renal disease, pulmonary edema, new onset cerebral or visual disturbances. Next. So we know now that preeclampsia can produce complications in any of the various systems of the body. It could be cardiorespiratory, could be neurological, renal, hepatic, and hematological. Next. So when to initiate antihypertensive is the million-dollar question. NICE guidelines say that only start therapy when the blood pressure exceeds 150 by 100. ACOG recommends treatment only for blood pressures over 160 by 110. WHO guidelines specified that the evidence is not yet sufficient to determine which strategy is preferable, but ongoing study will clarify this issue in the near future. Next. But what is very important, please next. But what is very important is that avoid reducing the blood pressure below the lower limits 110 by 80 millimeters, which could lead to a risk of placental underperfusion. Yes, next. So treatment. Although it is recommended to start antihypertensives at 150 by 100, but the common practice in our country and in our practice is to start antihypertensives when the BP is 140 by 90 and it is not responding to the diet and the lifestyle changes. So drugs used are labetalol, 100 to 400 milligrams BD or TDS, maximum 1200. Nifedipine 10 to 20 milligram BD or TDS, max 120 milligrams. Hydralazine 25 to 50 milligrams BD, maximum 200 milligrams. And a combination of these drugs often gives a very good control. Next. Now, what about bed rest? Cochrane review, in our times when we were doing post-graduation, it was all about bed rest karo, bed rest karo. But now the Cochrane review of 4 RCTs says has compared bed rest with no rest in pregnant women with mild hypertension and found insufficient evidence to provide guidance for clinical practice. So bed rest is not to be prescribed. We must just tell her not to exert too much and she can move about a bit. So timing of delivery, if it's less than 37 weeks, expectant management with maternal and fetal monitoring is suggested. Beyond 37 weeks, delivery rather than continued observation is suggested. What about magnesium sulfate? A lot of hullabaloo is there. Give magnesium sulfate, Maxsulf. Universal use of magnesium sulfate therapy in preeclampsia without severe features is not recommended. Certain signs and symptoms are premonitory to seizures, and if they are there, then we should consider initiation of magnesium sulfate therapy so that eclampsia does not come in. Magnesium sulfate therapy should be initiated if there is progression to severe disease. So severe disease would be severe hypertension or severe preeclampsia. Coming to severe hypertension, it is defined as BP more than 160, 110. Even without preeclampsia, it is a severe condition. Requires parenteral antihypertensive treatment or oral nifedipine. IV labetalol and hydralazine are the first choice. induced labor if the gestational age is more than 37 weeks. If less than 34 weeks, give steroids. We can give steroids even up to 36 weeks. Postpartum BP is measured for 2 days daily, then twice or thrice a week till it becomes normal. Gestational hypertension is strongly associated with development of chronic hypertension in later life. An updated Cochrane systematic review of 35 trials has shown no significant difference regarding either efficacy or safety between hydralazine and labetalol or between hydralazine and any calcium channel blocker. Theoretical concern exists that the combined use of nifedipine and magnesium sulfate can result in excessive hypotension and neuromuscular blockade. So avoid using nifedipine and magnesium sulfate together. Now, maternal and fetal monitoring during expectant management for severe preeclampsia. I won't be going in details because the next speaker is going to speak on severe PET. So maternal assessment is done, vital signs, fluid intake, urine output should be monitored at least every 8 hours. Symptoms of severe preeclampsia should be monitored 8 hourly, presence of contractions, rupture of membranes, abdominal pain, all to be monitored and lab testing to be performed. For fetal monitoring, kick count and NST with uterine contractions monitored daily, biophysical profile twice weekly, and serial growth charts have to be seen. Next. So what about the role of antenatal corticosteroids? Women with severe preeclampsia receiving expectant management at 34 weeks or less of gestation, corticosteroid treatment results in less frequent RDS, neonatal death, and intraventricular hemorrhage. Next. So, do women with preeclampsia and their babies benefit from magnesium sulfate? MAGPIE trial, a randomized placebo-controlled trial was done. 50% to 67% reduction in the risk of seizures, reduction in the risk of maternal death, may have some benefit to the baby. 4 gram loading dose is given after the IV, and after that a maintenance dose of 10 grams is given, 5 grams in each buttock. And after that, every 4 hourly, we have to give 5 grams alternating in the buttocks. This is the Pritchard regime. Some are following the Zuspan regime also. So depending on that, it will be managed. Monitoring is to be done. Observation of urine output, respiratory rate, and deep tendon reflexes. Timing of the delivery, if it is less than 34 weeks and the stable maternal fetal conditions, then you continue the pregnancy. But do it in such facility where immediate cesarean can be done and immediate managing of the maternal and fetal conditions can be done. And if it is more than 34 weeks and the patient is unstable, then delivery soon after maternal stabilization is recommended. Next. Yeah, we won't go into this. Next. Now, eclampsia. Yes, eclampsia we'll just briefly touch. Occurrence of generalized tonic-clonic contraction, convulsions or coma in a woman with preeclampsia, which cannot be attributed to other causes. Maternal mortality 4 to 6%, perinatal loss 45%, incidence maybe 1 to 5.5% of all pregnancies in India. Next. Management, we all know, stabilize mother through the application of a standardized airway, breathing, circulation, disability, and evaluate approach. If eclamptic seizure is not terminated by itself, magnesium sulfate should be commenced. Further bolus of magnesium sulfate may be given, and we can maintain the infusion. Hypertension should be controlled as previously discussed. Next. Recurrent seizures may need intubation, so we'll have to take the help of a anesthetist. Fetal bradycardia will be seen in CTG, but seizure and BP control is the primary intervention. As soon as mother's condition is stable, she should be delivered by the quickest route, which may be vaginal, otherwise cesarean. Next. So HELP syndrome, we won't go into. That's a separate topic in itself. Yes, please skip HELP syndrome. Yeah, no, future health risks. Yes. Next. Women who have had hypertensive complications in pregnancy receive postnatal counseling regarding the management of future pregnancies. Women with gestational hypertension, risk of recurrence of hypertension in the next pregnancy is 16% to 47%, and of preeclampsia is 2 to 7%. Women with preeclampsia, risk of recurrence is 16% if delivered at term, 25% if delivered at less than 34 weeks, and 55% if they had delivered less than 28 weeks. Advised to book early in the next pregnancy, start low-dose aspirin as prophylaxis. Women on long-term antihypertensive therapy should be counseled to first stabilize their blood pressure before conceiving, should have more frequent blood pressure and urine dipstick monitoring, and if they have been delivered less than 34 weeks, should be screened for APLA syndrome. Yeah, to conclude, next. Associated adverse outcomes demonstrated by meta-analysis: increased risk of cardiovascular disease, chronic hypertension, venous thromboembolism, and cerebrovascular disease. Simple lifestyle modification suggested by the obstetric team and primary care physician to help reduce future risks, and as advised by Dr. Anita Sabharwal: weight loss, smoking cessation, low salt, and regular exercise. But one thing is sure, that the gold standard is that the definitive treatment of hypertension in pregnancy is delivery, because that is causing the problems. So before I say a thank you, I am standing for the post of FOGSI president this year. Voting shall be in August. So my sincere request to everyone that please do give me your vote and support, because we can do a lot still for the health of women in our country, and together we can and together we will. Thank you so much.
Thank you, ma'am, for this wonderful talk covering each and every part of hypertensive disorders. I would request Sonia, Malik, ma'am, please.
Ranjana has always been a great speaker, and she has summarized the whole thing so well, going from right from the beginning of pregnancy and going on and telling us how we should be treating the milder forms and how we should be treating the severe forms. And of course, she hasn't dwelled upon the severe forms very much because she is waiting for the next speaker to do it for us. But thank you very much, Ranjana. That was a wonderful overview. Thank you so much.
Thank you so much.
Even for someone like me who's not practicing anymore.
But
Thank
still.
Dr. Vijayashree, you want to say something?
Dr. Manju Varma.
Dr. Ma'am, hai kya?
Dr. Manju's there.
Yes,
Dr.
ma'am.
Manju.
Yeah.
Ma'am.
Hello.
Haan ji, ma'am. Haan ji,
Haan
ma'am.
ji,
Can you hear me?
Ma'am.
Yes.
Ranjana, my opening comment is that vote and support Ranjana for the post she's FOGSI president. My opening comment is that, and then I would like to say that really congratulations for summarizing such a huge topic into a few minutes rather than of saying in hours, because this is one condition which is very critical as far as it is being diagnosed. And there is one thing I would like to add over here is there is something called gestational score. So in which one score is given to certain conditions and 2 score is given to the certain conditions. So if the score is 3 or more than 3, at the time when the patient is first antenatal checkup, she comes, you can categorize from the very beginning and take care of her that she does not go into preeclampsia or hypertension in pregnancy. Very nice lecture, Ranjana, and I must congratulate you for giving such good things. And again, I would request everyone to vote and support Dr. Ranjana Khanna for the post of President FOGSI.
Thank you so much. Thank you so much, ma'am, for this. Thanks a lot.
Thank you, Varma, ma'am.
I endorse that.
Thank you so much, ma'am.
Oh, Sonia, so nice to see you.
And so also you, madam. So also you.
So thank you, Ranjana ma'am, Varma ma'am, Sonia ma'am, and everyone. I would hand over the session to my dear friend and Vice President of ISOPARB Prayagraj, Dr. Chitra Pandey. She had been a very able secretary of Allahabad Obstetrics and Gynecological Society. Over to you, Dr. Chitra Pandey, to conduct the second session.
Thank you so much for the kind words, Amita. Good evening, everyone. Once again, I welcome all the faculty members and all the delegates on board. After understanding the broad perspective of hypertensive disorder in pregnancy, let's move to our next session, that is talk on severe PET, a life-threatening condition of pregnancy. Early detection, close monitoring, and timely intervention are crucial to ensure best possible maternal and neonatal outcome, as well as to predict and manage long-term complications, as told by ma'am also, the future risk that is very important to predict and manage. Our learned speaker of this session is Dr. Sangeeta Sen. To chair this session, I invite our esteemed chairpersons, Dr. Punita Sharma and Dr. Khushbu Jain. Dr. Punita Sharma is consultant gynecologist at Radhakrishna Hospital, Chittorgarh, Rajasthan. She passed her MS in 2003 from RMT Medical College, Udaipur. Welcome, ma'am. Dr. Khushbu Jain is MD OBGY, FMAS, DMAS, and she's assistant professor at PBM Hospital, Bikaner. Welcome, ma'am. And now I request Dr. Punita Sharma to introduce the topic as well as the speaker of this session to the audience. Over to you, ma'am.
Thank you, ma'am. Very good evening to all the esteemed doctors of this conference. I would like to introduce Dr. Sangeeta Sen, ma'am. She is a senior professor and unit head of RNT Medical College, Udaipur. She is past secretary of UOGS, and she has some publications in national and international journals also. So I now request Dr. Sangeeta Sen, ma'am, to join us and enlighten us pre-eclamptic toxemia and its management.
In the meanwhile, while you're putting on your presentation, I want to welcome all our friends from Udaipur and Bikaner, and thank you all so much for joining and cooperating and giving a wonderful flavor to this webinar. Thank you all so much.
Good evening, Dr. Shyam Desai, sir, chief guest of this academic session, and guest of honor, Dr. Sonia Malik, ma'am, and Dr. Anita Sabharwal, ma'am. And thank you, Prayagraj Society, for giving me the opportunity to participate in this wonderful scientific meet on this very important topic. Ranjana, ma'am, your talk was very nice. You have very nicely elaborated the overview of hypertensive disorders of pregnancy. The topic given to me is pre-eclamptic toxemia and its management. Now, what is preeclampsia syndrome? It is best described as pregnancy-specific syndrome that can affect virtually every organ system. Although preeclampsia is more than simply gestational hypertension with proteinuria, the appearance of protein remains a primary diagnostic criterion. It is an objective marker and reflects the system-wide endothelial leak, and it characterizes the preeclampsia. So proteinuria characterizes the preeclampsia syndrome. It can be divided into 4 categories according to the onset. When it is appearing before 34 weeks of pregnancy, it is early onset. After 34 weeks, it is late onset. Preterm onset before 37 weeks, and term onset after 37 weeks. Earlier, it originates, the grave are the complications for mother and the baby. This is the table from Williams' textbook, which shows that preeclampsia means hypertension plus proteinuria, which is more than 300 milligram in 24 hours, or urine protein creatine ratio of more than 0.3, or dipstick protein 1 plus, which is persistently present, or any of the other thing like thrombocytopenia, platelets less than 1 lakh per microliter, renal insufficiency where creatinine will be more than 1.1, or doubling of the baseline value. Liver involvement, liver transaminases levels may be twice the normal, and cerebral symptoms, presence of cerebral symptoms in form of headache, visual disturbances, and sometimes when it lands into other complications of convulsions and eclampsia. Pulmonary edema may be one of the manifestation of preeclampsia syndrome. Now, the incidence of preeclampsia is 5 to 8% of all pregnant women. In nulliparous women, it is higher, between 5%, 3 to 5%, while in multiparous, it is between 2 to 5%. It is also influenced by race, ethnicity, and genetic predisposition, with Black women having higher risk for associated severe adverse outcome. This table shows some risk factors for the onset of preeclampsia syndrome: nulliparity, age more than 35 years, BMI more than 30, multifetal gestation, prior abruption, diabetes, prior preeclampsia, chronic hypertension, prior history of stillbirth, chronic kidney disease, assisted reproductive technique, as Madam Sonia Malik already told about this, systemic lupus erythematosus, and antiphospholipid antibody syndrome. When we talk about the etiological factors of preeclampsia, the cause may be failure of trophoblastic invasion, that is abnormal placentation, vascular endothelial damage, inflammatory mediators or cytokines. There is immunological intolerance between maternal and fetal tissues. Coagulation abnormalities produced because of the various changes of preeclampsia. Then increased free oxygen radicals. There is imbalance of angiogenic and anti-angiogenic proteins in pregnancy with preeclampsia. That causes basic pathophysiology of event. Then genetic predisposition may occur. What happens in normal pregnancy? There is the angiotensin 2 is destroyed by angiotensinase enzyme, which is liberated from placenta. And there are vasodilator factors like nitric oxide, PGI2 are secreted. And vascular endothelial growth factor is secreted, which restores the uteroplacental blood flow to normal level. But in what happens in preeclampsia? The reverse thing happens. The angiotensinase enzyme levels are low, the sensitivity to angiotensin 2 is increased, and the levels of vasodilator, PGI2 and nitric oxide are low, and VEGF is also decreased. So this imbalance between the vasoconstrictor and vasodilator factors, along with the inflammatory mediators, endothelin-1, and these placenta-like growth factor, it causes disbalance between the vasospasm and vasodilator, and ultimately the pathogenesis of preeclampsia occurs. This is the picture showing glomerular capillary endotheliosis because of preeclamptic changes. When we will call it as a hypertensive disorder with severe features. When diastolic blood pressure is more than 110, systolic blood pressure is more than 160 millimeters of mercury, proteinuria of higher grade, headache, visual disturbances, upper abdominal pain, oliguria, and convulsions may occur in turn. Serum creatinine levels will be elevated, thrombocytopenia less than 1 lakh per microliter, elevation of liver enzymes, marked elevation of liver enzymes, fetal growth restriction is occurring, pulmonary edema, or early onset of preeclampsia. That is also a severe type. Whenever patient comes in for the antenatal checkup, we have to consider about the alarming symptoms. Patient is complaining of headache, disturbed sleep, sometimes diminished urinary output. So we have to take into account these factors, and we have to examine and evaluate the patient carefully. Epigastric pain patient may complain of, which is because of associated with hemorrhagic gastritis and subcapsular hemorrhages in the liver also. Eye symptoms patient may complain of in form of blurring, scotomata, dimness of vision, or sometimes complete blindness. So during antenatal checkup, we should carefully listen about the patient symptom. When we examine the patient, we may find abnormal weight gain, a rapid gain in weight of more than 5 pounds a month or more than 1 pound a week in later months of pregnancy. It is significant. Rise of blood pressure, of course, it will be present. Edema, generalized edema, anasarca may be present without any manifestation of chronic cardiovascular or renal pathology. Patients sometimes may present with pulmonary edema due to capillary leaks and low oncotic pressure. And when we do parabdominal examination, we may find height of uterus less than period of amenorrhea because of the intrauterine growth retardation and oligohydramnios. Now, what are the complications of pregnancy? Complications may occur anytime during pregnancy, during labor, and during puerperium. The very grave complication of preeclampsia is eclampsia, which may occur in 2% of the cases during pregnancy. It may also occur during labor or during puerperium within 48 hours. Then during pregnancy, intracranial hemorrhage may occur, oliguria and anuria, renal affection will occur, retinal affection, dimness of vision, and even blindness will occur. Preterm labor and placental abruption may occur. Then patient may undergo HELP syndrome, where liver enzymes will be elevated, hemolysis will occur, platelet counts will be low. So, and acute respiratory distress syndrome may occur. So, it can affect each and every organ of the body. During labor, patient may undergo placental abruption and fetal demise may occur because of that. During puerperium, sudden obstetric collapse may occur because of sudden fall in corticosteroid levels. Then there are high incidence of sepsis because of increased incidence of induction of labor and operative interference, and also because of low vitality of the patient. Postpartum hemorrhage is also higher in incidence in patients of preeclampsia, which may be related to coagulation failure. Fetal complications, they will depend upon the severity of preeclampsia, duration of the disease, and degree of proteinuria. Intrauterine fetal death may occur, which is due to spasm of the uteroplacental circulation, leading to accidental hemorrhage or acute red infarct. Then intrauterine growth restriction may occur due to chronic placental insufficiency. Fetal asphyxia may occur. Prematurity, which may be either due to spontaneous preterm onset of labor or abruptio placentae, or due to preterm induction of labor for preeclampsia. Some of the remote complications in form of residual hypertension, which may persist even after 6 months following delivery in about 50% of cases. Recurrent preeclampsia may occur in 25% cases in subsequent pregnancy. Chronic renal disease is also found in higher incidence in form of glomerulonephritis in women with history of preeclampsia. Then in the next pregnancy, there are higher chances of placental abruption, preeclampsia, and HELP syndrome in about 5 to 20% cases. Now, predictors of preeclampsia. Certain tests and markers are suggested for the prediction of preeclampsia. Rollover test, in which from lateral to supine position, when patient turns, there is 20 millimeters of mercury, BP is raised. So there are 30% of chances in these cases for preeclampsia. Angiotensin 2 infusion drip will increase the BP by 20 millimeters of mercury, but positive predictive value of this test is not much. Uterine artery Doppler, very important diagnostic method. Raised pulsatility index and diastolic notching in uterine artery Doppler is predictive of preeclampsia in present pregnancy. Then feto-placental unit endocrinal dysfunction. Certain markers, biochemical markers are raised in patients who are predictive of preeclampsia, like HCG, alpha-fetoprotein, tyrosine kinase, fibronectin, inhibin, activin, and corticotropin releasing hormones. These markers are raised in patients who are going to develop hypertensive disorders of pregnancy. Serum uric acid levels are more than at 8, microalbuminuria, urinary kallikrein, calcium. These all are the biochemical markers which are suggestive of prediction for development of preeclampsia. Now coming to the management part. What are the objectives of management of preeclampsia? The main objective is to stabilize the hypertension and to prevent its progression to severe preeclampsia, and to prevent the development of complications, as it can affect each and every organ of the body. We have to prevent those complications. We have to prevent development of eclampsia, and our aim is to deliver a healthy baby at an optimal time, neither no much preterm nor too late. So at optimum time, delivery is to be planned. Then the restoration of health of the mother in puerperium. So ideally, all patients of preeclampsia are to be admitted in hospital for effective supervision and treatment and for the initial evaluation. For initial evaluation after hospitalization or on outpatient basis, we have to do detailed examination of the patient, including general physical examination, obstetric examination, and it is coupled with daily scrutiny for the symptoms of headache, visual changes, or epigastric pain. Then daily weight measurements to identify rapid weight gain. Then albuminuria has to be detected. Quantification of proteinuria or a urine protein creatine ratio has to be measured. Blood pressure readings with an appropriate size cuff every 4 hours, unless it was previously elevated. If it was previously elevated, then we have to mandate more frequent readings. Otherwise, we have to measure it 4 hourly. Then some lab testing has to be done. Measurements of serum creatinine, hepatic transaminases level, and a hemogram that includes platelet count, and the frequency of testing is determined by hypertension severity. Some recommend assessment of uric acid and lactate dehydrogenase levels and coagulation profile, but their value has been questioned. Evaluation of the fetal growth and well-being and amniotic fluid volume assessment has to be done by clinical examination and ultrasound. When the patient is hospitalized, her physical activity is reduced. That may have benefited. That may have benefits, although evidence is not robust. These are the NICE guidelines for the management of pregnancy with preeclampsia. The patient is hospitalized and she may have hypertension. The BP, if it is below 160 by 110, then it is included in the category of mild to moderate. And if it is more than 160 by 110, it is in category of severe hypertension. In mild to moderate, we may admit the patient if there is high risk to mother and baby. Otherwise, we may discharge the patient after initial evaluation. But in severe hypertension, we have to keep the patient admitted and we have to manage for her hypertension. Antihypertensive agents have to be initiated if BP is more than 140 by 90. And in severe hypertension, we have to give the pharmacological agents to treat the hypertension. Blood pressure measurement has to be done every 48 hours in cases of mild to moderate hypertension. But if it is severe hypertension, we have to measure the BP every 15 to 30 minutes until BP is less than 160 by 110 millimeters of mercury, then at least 4 times daily while the patient is in inpatient. Blood test, we have to go for complete hemogram, renal function test, liver function test. For mild to moderate hypertension, we can go for lab testing twice a week. But for severe hypertension, it should be done more frequently, maybe for 3 times a week. Then fetal assessment has to be done. Fetal heart, in both categories, fetal heart rate to be heard at every visit. Then ultrasound assessment of the fetus is done. And if it is normal, then ultrasound should be repeated every 2 weeks. Cardiotocographic assessment is done at initial visit, and then only if it is further indicated, further symptoms of deterioration arises, then it is done more frequently in cases of severe hypertension. When preeclampsia is without severe features, we have to do certain things. We will advise her rest in lateral decubitus position. That will decrease the vena cava compression and it will increase the renal blood flow and uterine and placental perfusion, and it will again help the fetus fetal blood flow. Then the diet, which is rich in protein, maybe up to 100 grams per day, good calorie intake and good calcium supplements. Fluid and salt intake should not be restricted or forced. So it should be in balance. The salt intake should not be restricted. The role of diuretics, usually they are avoided as they have got adverse effect on fetus, but there are certain indications for their use. They are used in pulmonary edema, heart failure, anasarca. If there is general edema, we have to use them. And sometimes with some antihypertensive drugs, we have to use the diuretics. Otherwise, they are not indicated. And we can use furosemide 40 milligram per day orally. The antihypertensive which are recommended for the treatment of hypertension are labetalol, which is given in doses of 100 milligram in BD doses. Maximum it can be given up to 24 milligram per day in 2 divided doses. It is a combined alpha and beta blocker, but the adverse effects are it affects the liver functions. It is contraindicated in asthma and congestive heart failure. Nifedipine, it can be given in doses of 10 to 30 milligram orally 3 times a day, maximum up to 120 milligram per day. It is a calcium channel blocker and it causes vasodilatation by smooth muscle relaxation. The adverse effects are headache, edema, and allergic hepatitis. Then atenolol, which is a beta-1 blocker. It is used in doses of 50 to 100 milligram orally OD. It causes intrauterine growth retardation and it may mask symptoms of acute hypoglycemia also. So it is not a first-line drug. Methyl-dopa, 250 milligram orally 3 times a day, maximum 2 gram per day. It is a centrally acting drug. The adverse effects are it causes dry mouth, somnolence, and postural hypotension. FOGSI Gestosis ICOG 2019 recommendations for the use of antihypertensive say that labetalol is the first line and effective medication during pregnancy. But it cannot be used in cases of bradycardia. The pulse rate should be more than 100 for its use. And nifedipine, it is the second line. It can be used when the pulse rate is less than 100 beats per minute. But it is never to be used sublingually. It has to be given orally. And methyl-dopa, which is nowadays it is not routinely available, but if it is given, then it should be discontinued in postpartum period to avoid postpartum depression. Now, what is the role of daycare unit? If diastolic blood pressure is less than 100 millimeters of mercury, then patient can be discharged. And if there is no sign of worsening, we have to advise her daily BP monitoring, and she should be explained about warning signs of preeclampsia. If she experiences any excessive edema, feet, or visual disturbances, epigastric pain, bleeding, then she has to report to the hospital immediately. Fetal monitoring is required. Patient has to be told about the daily fetal movement chart, and it should be at least 10 or more per day. Non-stress test can be done weekly, and ultrasound assessment for the fetal well-being is done every fortnightly. If the deterioration occurs, it can be done more frequently. Now, if the preeclampsia is with severe features, first thing, we have to hospitalize the patient immediately. Then rest is advised. Then daily maternal vital monitoring, as discussed previously, pulse, BP, respiration, urine output, all things to be measured daily and frequently on per day basis. Then antihypertensive treatment is started. The antihypertensive drugs which can be given are labetalol, hydralazine, or nifedipine. These are the FOGSI 2019 recommendation for the use of antihypertensive drugs in cases of severe preeclampsia. Nifedipine is given in doses of 10 to 30 milligram orally, not sublingually. If BP is not controlled, the drug is repeated within 30 to 45 minutes, and it can be given at the maximum 120 milligram. Once the blood pressure is controlled, then the slow release preparations are maintained. As discussed previously, it is contraindicated in congestive heart failure and AV and SA node abnormalities. Labetalol, it is given with slow IV injections in doses of 10 to 20 milligram IV, and if the BP is not controlled, then the dose is doubled 20, 40 and 80 milligram every 20 to 30 minutes, and maximum we can give 300 milligram doses. Alternatively, infusion of the labetalol also can be given. The drug is contraindicated in congestive heart failure, diabetes mellitus, asthma, and bradycardia. Then hydralazine, it is initiated in doses of 5 milligram IV or IM. Then 5 to 10 milligram is increased every 20 to 40 minutes till the BP is controlled. And then it is repeated every 3 hours. Or infusion of hydralazine can also be given. But the complications of mother and fetus are more with the use of hydralazine, like maternal hypotension, the higher incidence of cesarean section, placental abruption, and oliguria are higher with hydralazine. Nicardipine is another drug which can be given at a dose of starting dose 1.5 milligram per hour. It is more water soluble than nifedipine, so it can be administered IV and it can be easily titrable. Now, the role of corticosteroids. Corticosteroids are recommended in all women delivering before 34 completed weeks, and in cases of elective cesarean delivery before 38 complete weeks. The dose of IM dexamethasone is 6 milligram 12 hourly, 4 doses, or betamethasone IM 12 milligram every 24 hour, 2 doses. And these doses will reduce neonatal respiratory distress. Even a single dose of steroid at least 1 hour prior to delivery can reduce the neonatal respiratory distress syndrome remarkably. So if we are going for an emergency cesarean section or immediate delivery of the baby, then at least give single dose of steroid. Now for the progress chart of the patient who is in admission, daily clinical evaluation, and we have to ask for any symptoms like headache, right upper quadrant or epigastric pain, visual disturbances, oliguria, or any other fresh complaints. BP has to be measured at least 4 times a day. Then edema and daily weight record has to be maintained. Fluid intake and urine output has to be measured. Urine examination for protein daily, and if present, to estimate its amount in 24 hours urine, or we can go for dipstick test. Blood for hematocrit, plus platelet count, uric acid, creatinine, and liver enzymes, and coagulation profile may be done at least once a week. Ophthalmological examination is done first on admission, and it has to be repeated if necessary, if there is further deterioration of the features. Then the fetal well-being assessment is done of IPD patient. For fetal monitoring in preeclampsia or severe hypertension, cardiotocography is done at the diagnosis or in first visit. Then, if conservative management of preeclampsia or severe gestational hypertension is planned, then ultrasound for fetal growth and amniotic fluid assessment is done. Umbilical artery Doppler velocimetry is measured, and if everything is okay, then it has to be repeated every 2 weeks. But if there are changes, then we may do is more frequently. In women with preeclampsia or severe gestational hypertension, repeat cardiotocography is indicated if any of the following things occur. If women reports a change in fetal movement, if there are decreased fetal movements, we have to go for cardiotocography. If there is vaginal bleeding, abdominal pain, or deterioration in the maternal condition, so we have to go for the fetal assessment at that time. Duration of the treatment, how long we have to give this conservative treatment. The aim of treatment is to continue pregnancy equal to 37 weeks. But it will depend on the severity of preeclampsia, duration of onset of preeclampsia in pregnancy, response to the treatment, whether the patient is responding or not. Then cervical Bishop score. We can understand this by grouping the patient in 3 categories. In group A, the patients who are having preeclamptic features, but after admission and treatment, the features are subsiding and hypertension is becoming mild. And if at this stage, the duration of pregnancy is remote from term, then the patient may be discharged with advice to attend the antenatal clinic after 1 week and she has to report earlier if she notes any warning signs of preeclampsia. If patient is near term, then she has to be kept for few more days in hospital till the completion of 37 weeks, and then she has to be delivered, even if the hypertension is mild. In group B, there is partial control of preeclamptic features, but the blood pressure is maintained still at a steady high level. It is not becoming 140/90 or lower. And in this case, if the patient is more than 37 weeks, delivery has to be considered without delay. But if she is less than 37 weeks, then expected management may be extended judiciously, at least up to the gestational age of 34 weeks. But for this, careful maternal and fetal well-being are to be monitored during this period. Group C patients are those who are having persistently increasing BP to the severe level despite the use of antihypertensive. In these cases, termination of pregnancy is considered irrespective of the duration of gestation. Seizure prophylaxis should be started in the form of magnesium sulfate in these patients. And if the gestational age is less than 34 weeks, steroid therapy has to be given. The NICE guidelines 2019 suggests threshold for planning of early birth. Early birth is indicated in cases of uncontrolled maternal BP despite using 3 or more classes of antihypertensive in appropriate doses, or maternal pulse oximetry is less than 90%, or progressive deterioration in renal or liver function test, hemolysis or platelet count, or the neurological features are appearing like severe interactable headache, repeated visual scotoma, or patient is developing eclampsia. In cases of placental abruption, we have to go for immediate delivery. If the Doppler is showing reverse and diastolic flow in a black artery Doppler velocimetry or a non-reassuring cardiotocographic pattern, then baby should be delivered immediately. And if the IUD has already occurred, then there should be immediate delivery. What are the indications of cesarean section? When an urgent termination is indicated and the cervix is unfavorable, it is unripe or closed, then we have to go for cesarean section. Otherwise, in severe pre-eclampsia patient with a tendency of prolonged induction delivery interval, then also we have to go for cesarean section. If there is any other obstetric complicating factor, like elderly priming, contracted pelvis, malpresentation, so any 2 complicating factors will require cesarean section. For cesarean section, epidural anesthesia is preferred unless there is coagulopathy. Postnatally also, patient has to be monitored. BP should be measured 4 times a day for 2 days till she is shifted to the ward, and antihypertensive agent should be continued till her BP comes below 140/90. If her BP becomes lower than 140/90, then we have to stop the antihypertensive treatment. If she was taking methyl dopa, it has to be stopped in postpartum period because it causes postpartum depression. Now, acute fulminant preeclampsia. Acute fulminant preeclampsia is the onset of preeclamptic manifestation in acute form. It is arising either de novo or if there is rapid deterioration in already established case of preeclampsia over a short period of time. So, treatment protocol is hospitalization, evaluation, antihypertensive treatment, magnesium sulfate therapy, and plan for delivery. Magnesium sulfate therapy can be given in form of intramuscular or Pritchard regime. Initial loading dose of 4 gram IV given slowly, which is followed by 10 gram IM, 5 gram in each buttock. IV regime can be given, Zuspan regime, 4 gram IV loading, followed by 1 to 2 gram per hour by controlled infusion pump. And this has to be continued 24 hours after delivery or last. Whenever we are giving magnesium sulfate in severe preeclampsia patient, we have to monitor the patient closely. Pulse, BP, respiratory rate, and saturation should be monitored every 10 to 30 minutes. Temperature and lungs should be auscultated every 2 hours. Deep tendon reflexes should be seen. Level of consciousness should be assessed, and headache, visual disturbances, epigastric pain, they should be monitored every 4 hourly. Intake output chart should be maintained. And along with this, fetal well-being has to be monitored. So continued electronic fetal monitoring is advisable. This is a flow chart of treatment of severe preeclampsia. The patient is diagnosed with severe preeclampsia. She is admitted to labor and delivery ward. Maternal and fetal assessment has been done. Then magnesium sulfate is considered in cases of severe features. Then hypertension is treated by drugs. Then we have to see for the contraindication for conservative treatment. If there is persistent symptoms or severe hypertension despite treatment, or if there is development of eclampsia, pulmonary edema, or HELP syndrome, or renal dysfunction or coagulopathy is developing, placental abruption has occurred, or fetus is pre-viable, it will not be viable, or if the fetal distress is occurring. These are all contraindication to conservative treatment. In these cases, we have to deliver the patient. If the cervix is favorable, we may go for induction or augmentation. But if it is not favorable, then we have to go for immediate cesarean section. If the contraindication to conservative treatment are not present, then we can go for 24 to 48 hours of observation. And during this time, we can give corticosteroids for lung maturation, and we can repeat our evaluation regarding vital signs. Then lab testing, all these can be done for the further evaluation. If the ongoing initial management is going well and fetal and maternal assessment is good, there is no further deterioration, then we have to continue the pregnancy till 34 weeks, and then we have to deliver. But if any time during these observation period or treatment period, patient develops contraindication or severity of feature increases, then we have to deliver the patient. So it was overall about the management of preeclampsia with severe features. Now, how we can reduce the risk of hypertensive disorders in pregnancy? The NICE guidelines 2019 suggest that during antenatal visits, the symptoms of preeclampsia should be explained to the patient, especially if she is having history in previous pregnancy like this. So she should be told about the symptoms of severe headache, visual problems, blurring, and pain just below the ribs, vomiting, sudden swelling of the face, hand, and feet. Then she has to report to the hospital immediately. So timely reporting to the hospital will prevent the complication to mother as well as baby. Aspirin should be started in doses of 75 to 150 milligram daily from 12 weeks till the birth of baby. And it has to be started in patients with previous history of hypertensive disease, then in patients of chronic kidney disease, autoimmune diseases, antiphospholipid antibody syndrome, or in type 1 or type 2 diabetes patients prophylactically. NICE guidelines do not recommend the use of magnesium, folic acid, antioxidants, fish oils, or garlic, or salt restriction during pregnancy. These things do not control the hypertension. So to summarize, I would like to say that severe preeclampsia still remains a major cause of fetal-maternal morbidity and mortality. Early prediction, diagnosis, and treatment improves obstetric outcome. In preeclampsia without severe features, pregnancy can be continued till 34 to 36 weeks with treatment and close monitoring. Preeclampsia with severe features needs hospitalization, aggressive use of antihypertensives along with anticonvulsants, and decision to terminate the pregnancy. Termination of pregnancy is the only cure. Thank you.
Thank you so much for extensive talk, and excellent talk covering almost all the aspects. It was such an extensive topic and you covered everything very nicely. Now I would request Dr. Khushbu Jain to give concluding remarks and her valuable inputs. Is she there?
It was a wonderful talk, Dr. Sangeeta, I must say. Very nice, completely covered the topic.
Thank you.
But one drug I really miss is alpha-dopa.
Yeah.
Because that was a very, very comfortable to use drug. I remember when we were PGs, it was always methyl-dopa which we used. And so comfortably we managed. With labetalol, at least I am not on that comfort level which I was always with alpha-methyl-dopa.
Yes.
Ranjana, can I add one thing?
Hanji, ma'am.
I would like to say yes, Dr. Ranjana. It is probably the Western media because labetalol is expensive. They tried to push it, and labetalol has got the problems. Long term, if we are using, it is associated with IUD and other fetal problems. So why should not we all make a group and sort of generate evidence against labetalol? Because now alpha dopa is no more available, and probably we missed the opportunity to publish it at that time.
The main problem with the methyl dopa was basically that the initiation of action on the BP was a little longer. It is about more than 24 hours, and that is why labetalol came into it. If you want to immediately reduce the blood pressure, then
but
you cannot do it.
labetalol is not so effective. Immediate reduction is only with nifedipine.
Yes.
If you give
That is what
nifedipine,
I'm
it
saying. It
causes
is not
immediate
methyl
fall.
dopa. The thing was that methyl dopa is being in use now because you want to lower the blood pressure as early as possible. That is was the main reason. And then
but
The
labetalol,
basic concept,
I'm not
methyl
finding
dopa
so
will
good.
take not less than 24 to 48 hours to
I
lower.
agree, ma'am. But
So with
it is
severe,
always
you
good.
cannot. With severe preeclampsia, you have to use either labetalol or nifedipine, depending upon the
Nifedipine
choice of a
causes.
person. Depending upon the choice of a person, whatever may be the experience. Though, so methyl dopa has a little short, the thing which it does not allow it to be used as often as possible. Because once the person start taking a labetalol and then you shift on to methyl dopa, and the two things taken together, so that the methyl dopa take care after 48 hours is not advised.
But methyl dopa is not available only, ma'am, now.
I think it is
It is not
No,
available.
ma'am. I
It is
tried
not.
very hard for one of my patients on whom labetalol was not affecting.
We never say that alpha methyl dopa is for the severe cases. It was never meant to be, but we all had very good experience with alpha methyl dopa.
Yes.
It is only the
No, there is
financial
no doubt
aspect.
about it. I
Same
have
as
used
saffron. They used
using
to
it in 1972. I've been
Yes.
using it, and I had a very, our generation has got a very good experience with methyl dopa.
And we really miss it. We really miss it.
It is to
Really.
you so very, very right, because it is not only the Western world, it is the pharma also that has resulted in all the changes.
It used to be very inexpensive drug. It was a very inexpensive drug. That
Yes,
is why
and the thing is that the monitoring has not to be that meticulous as it has to be with labetalol and nifedipine, because you have to have inpatient, if you want to give them these two drugs. And one thing also I would like to add over here is that the definition has a little change, in that it is not the proteinuria that has to be a must. The proteinuria with any signs of the end organ damage, maybe it is thrombocytopenia, maybe it is ALT that is increased. So with the proteinuria, of course, is definitely preeclampsia. But if proteinuria is not there, then we always give investigation. So if other things are there, then also it is labeled as preeclampsia.
Yes.
And I really welcome all the colorful Rajasthan, seeing people, but it's so nice to see them.
Dr. Khushbu, would you like to say something? I request Dr. Khushbu Joshi. I think she's here.
Good evening, all my seniors and colleagues. Now it's an honor for me to have words to speak among such eminent speakers and seniors. Thank you, ma'am, Sangeeta ma'am, for sharing such a valuable practical advices and insights. Thank you so much, ma'am.
So sweet.
Now, before handing over the session to Dr. Parul, I would request each and everyone to vote and support Ranjana Khanna ma'am for the post of President FOGSI in the upcoming election. We all have worked under her leadership, and she's so dedicated, efficient, and she has made us proud. And I'm very, very sure she'll make each and every FOGSian proud as President FOGSI. So please vote and support her in election of August 24.
Thank you so much, Chitra, for these lovely words.
Pleasure.
They are a morale booster, no doubt.
Ma'am, always with you. We have worked so much. We have seen you closely, working very, very hard. And learned so many things from you. So it's a pleasure. So now I would like to hand over the next session to Dr. Parul Khanna.
Thank you, ma'am. We now move on to our final topic of the session.
Parul, there is a question in the chat box for, I think, Dr. Sen. use of antepartum magnesium sulfate.
Magnesium sulfate, yes, Dr. Punita has asked.
Dr. Punita Sharma has
Dr.
asked.
Punita has asked, please enlighten on use of antepartum magnesium sulfate if patient has solely raised BP, not controlled by labetalol and nifedipine.
I think I had answered this question in my talk. That only when signs of severity come, then only you start, or if there is impending eclampsia, if you have some premonitory symptoms that the patient can go into eclampsia, then immediately you have to put the patient on magnesium sulfate.
I think they are asking that if we use magnesium sulfate, then as an antihypertensive, then I think it is must to deliver the patient thereafter, or we can wait, like without delivering the patient.
We can wait.
Usually
please enlighten antibiotic patient as
Usually
solely
we
raised.
deliver when magnesium sulfate is given, even for neuroprotection when it is given. Then after 48 hours, the patient are usually
within 24 hours, ideally should be delivered.
No, it is not like that. Though people say, Dr. Ranjana, you will agree. There used to be patient in eclampsia also. If Maxsulf is given, interval, we used to carry this patient as long as possible. But usually it happens, the patient, they don't carry too much.
Exactly.
After 3
So,
days, 48
as soon
to 72
as we
hours, they do go
stabilize
and deliver.
as soon as we stabilize the patient, we deliver. Because at the end of the day, the golden words are that the key
final
treatment is delivery.
Even if
once
it is
the
system, they
baby is
don't prolong
out
too
of
much.
the system, the mother is also safe. Now we are looking forward to Dr. Sudesh's talk. Dr. Parul, please go ahead.
We now move on to our final topic of the session, which is a talk on the most dreadful component of hypertensive disorders, that is the HELP syndrome. And the speaker is Dr. Sudesh Agarwal. I would now invite the chairpersons for the session. Our first chairperson is Dr. Amita Agrahari. She is consultant obstetrics and gynecologist and associate director at Phoenix Hospital, Prayagraj. Founder member of ISOPARB Prayagraj. She has been faculty at various conferences, and she has also been past president of Inner Wheel Club of Allahabad, Odisha. I welcome you, ma'am. Our next chairperson is Dr. Arihan Teter. He is associate professor, Government Medical College, Dungarpur, Rajasthan. I now request Dr. Amita Agrahari to introduce our speaker, Dr. Sudesh Agarwal, ma'am. Dr. Amita.
And introduction. I welcome you all to this fortunately indoor session of academics in this scorching hot weather. Our topic is HELP syndrome. As the mnemonic suggests, it is hemolysis, elevated liver enzymes, and low platelets. Our esteemed speaker today is Dr. Sudesh Agarwal. Madam is Professor, Department of Ops and Gynae, Sardar Patel Medical College, Bikaner, Rajasthan. Madam, please.
Thanks, Dr. Amita, for your kind introduction. May I request to kindly share the slides? Dr. Amita, you have got my presentation with you. Will you be able to share it?
Deepika, please.
Yeah, Dr.
Deepika, please do the needful.
Deepika.
Yeah, at the outset, I will thank Prayagraj Society for taking a step forward. And I wish all the best for the future endeavors of Dr. Ranjana. We would like to
so
see
much,
you
Dr. Sudesh.
as the president of our prestigious FOGSI.
Thank you so much.
Near
Thank you
future.
so much, ma'am. Thanks a lot.
Today is of course, eclampsia day. It was the disastrous disease yesterday, and it remains a monstrous disease today. In spite of so much of development and research, even today, we come to the conclusion, once PET is there, let the patient be out of this daldal. I call it daldal because we have to bring the patient out of this pregnancy. There has been a lot of discussion. Dr. Ranjana, Dr. Sangeeta, they have given a very extensive overview treatment management. I will restrict myself and limit myself to a few important clinical points so that we don't like we are all. I won't like to test your more patience. So let us move on to the topic HELLP syndrome. Next slide, please. Will I be able to change it? Okay. So just to keep you awake, I have added a few animations. The HELLP syndrome, as everybody knows, this is an acronym. It was coined by Weinstein, 1982. Hemolysis, elevated liver enzymes, and low plates. Actually, there is an endothelial disruption, platelet activation, aggregation, consumption, ischemia, and hepatocyte death. Come to the next slide, please. Incidence is reported to be 0.2 to 0.6% of all pregnancies. Of course, if it is a severe PET, the risk of HELLP syndrome increases up to 10 to 20%. And everybody please don't let this patient to go in HELLP syndrome because it is a dreaded disease. Mostly these patients present in the antenatal period, usually in the 27 to 37 weeks. And sometimes it can present in the postnatal period also, about 1/3 of the patient within 48 hours after delivery. Next, please. Etiopathogenesis, again, I will not go in the details. Everybody knows there are the periportal depositions of the fibrin. There is a consumption coagulopathy. There is a hemolysis. So leading to the disruption of the liver parenchyma. There is a ischemia, periportal necrosis, intrahepatic hemorrhage, subcapsular hematoma, and the presentation of the patient is accordingly. Mostly they come with the epigastric pain. And the irony is that because these are the such non-diagnostic kind of features. Patient comes with a malaise, some nausea, vomiting, some upper quadrant pain. That is why we always tell our junior doctor, our residents to please be very, very careful when they are taking history of the patients. Again, etiopathogenesis, it is a multisystematic disease. There is a vasospasm. Next slide, please. There is a hemolysis that is related to the microangiopathic hemolytic anemia. Again, there is a thrombotic lesions in the small blood vessels, thrombocytopenia, and a young one of the young audience has also come to our this clinic. That is so good. There is RBC fragmentation, and there is the presence of the fragmented RBCs and also the birth cells. Next slide, please. Next slide, please. There are few diagnostic features on the PBF. These are the spherocytes, schizocytes, reticulocytes, because it tells that there is a fast turnover of the RBCs. Then anisocytosis, triangular cells, helmet cells, birth cells, and polychromasia. All these are the features of the hemolysis. Next slide, please. And to diagnose hemolysis, important features are the increased LDH levels. That is more important because in nowadays, in the era of the fast food, we don't go for the PBF reports, etc. So if LDH is raised above 600, we believe that it is a case that is having the hemolysis. There is a presence of unconjugated bilirubin. Further, if bilirubin is there, it is cleared by the hemoglobin. Hemoglobin, haptoglobin complexes, they are cleared by the spleen. That is a sensitive marker. Though clinically, we are not in practice of doing the haptoglobin measurement, though it is a sensitive marker. Next slide, please. Next slide, please. Yeah, there is also important factor, that is the thrombocytopenia. Again, there are a lot of confusions because so many diseases during pregnancy, they present with the thrombocytopenia. So how to differentiate? If platelet count is less than 1.5 lakhs, the chances are that there could be gestational thrombocytopenia in about 60%, immune thrombocytopenic purpura, PET and HELLP syndrome almost equal. So platelet count less than 1 lakh are rare in PET and gestational thrombocytopenia, but it is frequent in ITP and obligatory in HELLP syndrome, as is reported by Sivai et al. Next slide, please. Plasma glutathione S transferase alpha 1. Again, it is a sensitive marker, but we are clinically not using it. These are the some substances which are more in the research use. AST, you rather we use the SGOT and SGPT values. Those are raised, telling us that the liver is damaged. Classification, different systems of classification are there. One is the Tennessee classification, other is the Mississippi classification. There are the three parameters that is important: platelets less than 1 lakh, AST or SGOT, SGPT above 70, LDH more than 600. In Mississippi classification, they have further subdivided it according to the severity of the platelet utilization, platelet deficiency. Next slide, please. There is one more way of classifying, that is the partial and complete health syndrome. Complete health syndrome is when all three features, that is microangiopathic hemolytic anemia, liver damage, and thrombocytopenia are present. If any one or two are present, then it is known as the partial health, and this makes the presentation of disease and diagnosis very, very challenging because these features are present in many of the other diseases. Next slide, please. So we come to the differential diagnosis. Very important, and that is the real challenge when we are examining these patients. Here I have mentioned only a few because this list could be exhaustive, and especially nowadays, in recent past, we have seen even corona has causes of thrombocytopenia, and so many infections they cause it. So I just left it. There are few other conditions like thrombotic microangiopathies, TTP, microangiopathic hemolytic anemia, some connective tissue disorders like SLE, primary renal diseases, glomerulonephritis, fibrinogen consumption disorders, etc. Next slide, please. Next slide, please. There are the few other differential diagnostic features like hepatic encephalopathies, viral hepatitis, peptic ulcer, pyelonephritis, appendicitis. So many diseases are there. So we have to pick out the right diagnosis, diagnose it timely, and treat it immediately because again and again we say it is a dreaded disease. Next, please. Management. How to manage this patient. So just a few words about it. As has already been discussed, the important thing is we have to keep the high suspicion index, high index of suspicion. Then only we are likely to diagnose. Otherwise, it might be easily missed. We have to anticipate, evaluate the maternal condition. Therefore, the management, it is important that we evaluate the maternal condition, fetal condition, control the hypertension. We have to provide prophylaxis of convulsions, or I should say eclampsia. Water and electrolyte balance is essential. Chemotherapy or blood products, transfusions may be required. There is a management of labor and delivery, optimization of perinatal care, intensive postpartum treatment of the patient, and be alert for the multiple organ failure, and for finally advice on the future pregnancy. Rest of my talk will be on these topics, but I will try to be very concise. So just don't lose patience. Next slide, please. Maternal evaluation, what are the important things? Of course, platelet counts we have to measure, liver enzymes, renal functions, bilirubin, especially unconjugated bilirubin. Usually there is only moderate increase in the unconjugated bilirubin, say up to 1.2 mg/cent. Serial evaluations are very, very important instead of one final value. Differential diagnosis, as we have already discussed, those need to be done. And please keep the high index of suspicion in your mind to diagnose this condition. Next, please. Fetal evaluation. Okay, fetal evaluation, of course, for important thing is the gestational age, because it is going to guide us for the treatment and the management options. Then we have to find any signs of the fetal distress and decide accordingly. It is always a good practice because if such patient is there, that should be managed in a center where it is well equipped with the obstetric ICU and the neonatal ICU where the preterm babies can be taken care of. Preventing conversion, Maxulf, and if Maxulf somehow cannot be used, then phenytoin may be used. Again, I will not go in the detail. It has already been discussed. Next slide, please. water and electrolyte balance. That is the very, very important. We happen to discuss so many things, but this kind of important thing sometimes that goes unnoticed. So we have to take care. If there is a negative balance, there is a possibility of vasoconstriction. If there is an excessive positive balance, so pulmonary damage or pulmonary edema may occur. Urine output is to be well maintained at the 30 to 40 ml per hour. Input should be limited to the liquids up to 150 ml per hour. Electrolyte measurement and correction is essential. And it is better that you measure the pulmonary capillary bed pressure continuously, as is the practice nowadays in the ICU. That is why well-equipped center is very, very essential. Next slide, please. Chemotherapy. Yeah, please, previous slide, please. That is important. Here, the important thing is, many a times there is question when to transfuse platelets, whether platelets to be given or not to be given. Many people think that platelets, because they are associated with the hemostasis, if there is a low platelet, there is a risk of hemorrhage. Here, because so many senior obstetricians are here, I would, after so many years of practice, I would submit that, of course, platelets are very important. And if they fall below the 50,000, we all are very, very hyper in our mind that this patient might have KPN. But again, we have to think the hemostasis during delivery is because of the contraction of the uterine muscles. That leads to the formation of the clot. Even if there is a low platelet count, and if you are careful enough, you are neither giving too big episiotomy or nor giving too small episiotomy, so that there are like tears or something, then probably you can minimize the chances of the hemorrhage. The guideline says that maintain the counts above 50,000 for if it is for the abdominal deliveries, and more than 20,000 for the transvaginal deliveries. Dexamethasone, it can be used in two ways. One is for the pulmonary maturity, prophylactic pulmonary maturity. Another dexamethasone use is especially in presence of HELP. It can be used in the therapeutic doses. Some other options are the plasmapheresis and immunoglobulins. Next slide, please. Management of labor and delivery. Again, I will not go in the details. In itself, it is a very big topic, and most of it has already been discussed. Next slide, please. Optimization of perinatal care is essential. Again and again, I have to stress that you have to keep high index of suspicion. If such a patient is there, it should be managed in high dependency unit or better in the obstetric ICU. There should be well-equipped neonatal nursery, neonatal ICU, and the early and the final treatment is the early termination of the pregnancy. Nowadays, neonatal care has advanced very much. Even if the baby is a preterm and you have taken proper care, stabilize the patient, and then you deliver, probably baby can be given the new life. Next slide, please. Previous slide, please. Postpartum intensive care. Again, after delivery, please do not leave the patient. These patients are at very high risk even after delivery, and for next 48 to 72 hours are really very serious. If there is a persistent low platelet count, or there are the delayed liver functions, or increased LDH level, it indicates probably patient is going into multiple organ failure. So you have to manage it accordingly, taking the multi-speciality clinical team and doing the all possible monitoring. Next slide, please. BP, of course, is to be managed, that we have already discussed. Use of dexamethasone, again, as I told you, dexamethasone, it has to be used twice, means in two ways. If the patient is less than 34 weeks, we use the standard doses of the steroids for the lung maturity. Another use of dexamethasone, though it is not proven yet by the CCTs, but because this is a rare disease and real CCTs are not possible, some reports are there that dexamethasone, if given in the high doses, it can be life-saving for the patient. But in these cases, please do take care that high doses of dexamethasone, they have their own negative mark on the fetal health. Next slide, please. Be watchful for the complications, for the signs of multiple failure, subcapsular hepatic hematoma, hemorrhage. Keep your fingers crossed. Hepatic rupture. If hepatic rupture is there, probably God can save. So all surgical, conservative, liver transplantation, if it is available, probably that can come. But this is a really deadly disease and is likely to have the serious effect on the mother and baby both. Next slide, please. Future pregnancies, of course, there is a risk of recurrence, as has been told. And as I came to know, Dr. Sonia, she talked about the HLA testing, about the genetic aspects. Nowadays, a lot of work is being done. We do not know. And there are two things. One, severe PET is there. It has been shown in the epidemiological studies, the lifespan of mother decreases by minimum 10 years. There is, of course, high risk of development of the other NCDs later in life. In future pregnancies also, there is chances of recurrence. Risk of recurrence of preeclampsia, eclampsia is about 40%. HELLP syndrome is about 25%. Or if there is a preterm delivery, means the disease starts early in the pregnancy. That means the chances of recurrence are very high. So we have to counsel the patient accordingly. Next slide, please. Take home message is there. My experience is, if we come across, means sometimes there's hardly a patient who has been through HELLP syndrome or severe PET and still wants to have the second baby. Mostly they will say, oh, no, doctor sahab, ab aur himmat nahi hai. Ab aur himmat nahi hai. Because this is really such a deadly disease. It is not only we as a doctor, patient also suffers a lot. Take home message is, it is an important entity. It is mostly present, associated with severe PET. High rate of suspicion is very, very important. If we can diagnose it early, probably we can make a difference in the outcome. Presentation is variable, so you have to be really watchful for this. Early intervention is important. Finally, termination of pregnancy is the only answer, and vigilance in early postpartum is again must. Next slide, please. With this, I will thank you all for patiently listening after such a exhaustive talk and a busy day. Thank you so much.
But
And
one thing I would like to say,
Huh?
Dr. Sudesh, I would like to say one thing, that you are an extremely lucid speaker. I was gripped to the screen and your talk throughout.
Thank you, ma'am.
Extremely lucid talk.
Next time कभी आप क्या आएंगे प्रयागराज?
हाँ जी, बिल्कुल, बिल्कुल.
ठीक है, ma'am.
Most welcome.
Animations were too good, ma'am.
Okay, thank you, thank you. Because they keep the mind little diverted, na?
Exactly. They prevent the boredom from creeping in because the topics were very heavy.
Yeah.
So, but really very well said. And
I hope it did
another
some
thing
work.
is that I think that platelet should only be transfused if there is an emergency procedure to be done.
Yes.
Because otherwise, our COG says that if you keep on transfusing platelets, then platelet antibodies develop. And then
Yes.
you can't transfuse platelets only, they won't be effective.
And one important thing is, ma'am, clinically what I want to convey after, so I am also in practice for more than 30 years.
Hanji.
And important thing is that platelets, they have a very short lifespan.
Short life, 5 to 7
and
days.
second thing, whatever reports the lab people give, that is never reliable because platelets, they have a tendency to make clumps. Third
Yes.
thing, whenever there is a consumption, what happens, after consumption, there is a heavy turnover. The auto analyzers, they are like calibrated to read the certain dimensions. When there is a heavy turnover, the new platelets are usually bigger in size. So they miss those platelets.
They
we
they
actually
report it
cannot,
as
we
they
cannot
report
like,
they report those as lymphocytes.
yes, yes. And nowadays it is really very difficult to ask some pathologists to do it manually. But
Manual,
even,
yeah.
yeah, it is not possible. But clinically, we have to, like, we are the ones who are answerable to the patient. And whenever we are transfusing, whatever is there, it may be very fresh. Still, the life is so short. You
Yes.
will be transfusing more of the dead platelets.
Yes.
And there are no studies to tell us what is happening to those, because there's already consumption coagulopathy, already endothelium is so much damaged, they are getting sequestered in the spleen. So the more thing is that we have to be confident in ourselves. And over the years, I have seen if there is a less number of platelets, I'm not talking about 10,000 or no, I don't know, whatever. After that, even I am shaking. But even if it is less, you take the adequate care, make the uterus contract easily, be watchful, better give a chance of vaginal delivery if all other things are like suitable.
Yeah.
Yeah. And the episiotomy has to be like, that is the real savior at that time. Neither it has to be big nor to be small, and it has to be like still very meticulous. If you do it properly, then there are no hematomas. Otherwise, only
and then if you have diagnosed ITP and platelet levels are falling down, then it's better to do a splenectomy rather than wait, for the patient to go up.
During pregnancy, doing splenectomy is not all that easy, man.
They
Yeah, the
recommend
rarest
it
of rare cases, you can think
after
over it.
second trimester. In the second trimester, they say you can do it because
You can
it
do
could
it.
be
But
life
how many you
saving.
have done, ma'am? How many you have done over your
I
course? I have never done. I have not done. So whatever, see,
I've
I am
never
of the
even
kind,
called the surgeon to do it.
we do read. We do read. It is, but it is not the foreign literature. They can tell us. We have worked it, and we have done very consciously. We have worked.
Yes.
It is not like alpha methyl dopa. Like there used to be, if you recall, there used to be one antibiotic, Septron.
Yes.
Because those were the cheaper drugs. Nobody wants to sell them off, though they were very good. For alpha dopa, they say because it causes depression, it causes some changes in the alpha receptor in the brain. But how effective it is, each and every drug has got its negative share. And we are prey to their pharma strategies.
I think we have also had a good discussion, so we can.
Yeah.
It was a very nice talk by Dr. Sudesh, no doubt about it.
Must say, ma'am, you are a very good professor. We are indeed very lucky to have you.
It was almost like being in the classroom again. नहीं मैम, हम तो टीचर्स तो हमेशा ही लर्नर्स होते हैं ना. The day we stop learning, we become old. Yes. The day we stop learning, so we are always learners.
So, मैम क्वेश्चन आंसर्स भी कंप्लीट हो गए तो वोट ऑफ थैंक्स पे चले जाएं.
हाँ.
So after this great scientific sangam of stalwarts from all over the country, the time has come for formal vote of thanks. My sincere gratitude to Allahabad, Udaipur, and Bikaner Obs and Gynae Society for coming together to make this a webinar a success. My heartfelt thanks to ICOG office for always granting us for ICOG point. This time they have granted us 2 ICOG point. I want to thank our chief guest, Dr. Shyam Desai sir, for his gracious presence. Dr. Sonia Malik ma'am, your presence always fill any academic session with a beautiful hue. Dr. Anita Sabharwal ma'am, for your kind blessings. My sincere thanks to our expert, scientific expert, Dr. Manju Varma ma'am, for always guiding us on the right path. My sincere thanks to our chairpersons, Dr. Rajshree, Bisa, Dr. Pradeep, Dr. Punita, Dr. Kushbu, Dr. Amita, and Dr. Rihan for their valuable inputs. I can't thank enough of the speakers of today. Dr. Khanna ma'am, for your brilliant talk. I have, as Dr. Chitra has told, we all have worked with her since very long and learned a lot during this time. And you are a great leader, great motivator, and a lovely human being. And we all pray that you will be success in your endeavor. And we all request to all the societies to please help us in this endeavor. My sincere thanks to Dr. Sangeeta Sen for her wonderful, extensive talk covering all the points regarding the preeclampsia management. And my gratitude to Dr. Sudesh Agrawal for her beautiful explanation of such a difficult topic and one lovely slides We as that we are glued to the screen. My thanks to my Dr. Uma, Dr. Parul, Dr. Chitra for helping us in this moderation. And thank you, Jagsonpal, especially Dr. Deepika Chavda for always helping us in this our monthly webinar.